Good afternoon. Thanks everyone for joining us for this symposium presenting the very preliminary results from a project supported by United entitled the endTB project. Today, my name is Carol Mitnick, and this is not Francis Varenne. Unfortunately, he wasn't able to come, but we have the pleasure of Elena Huerga from MSF as the co-chair for this session, and we'll be presenting results from 4 of the 14 sites in the endTB project. And we'll start with an introduction by Elena, and then the next speaker. Thank you.
Good morning. So in this session, we are going to present some preliminary results from the endTB project. The endTB project is a partnership between Partners in Health, Médecins Sans Frontières, Interactive Research and Development. It's founded by United. It's a project that with a duration of 4 years and a budget of 60.4 million USD. So the aim of the endTB project is to expand access to new TB drugs. It's been implemented in 15 countries, and it will treat at least 2,600 patients. It includes close monitoring of adverse events, and one of the components of the project is clinical trials with novel regimens, including bedaquiline and delamanid. So all this is to produce evidence on new TB drugs that will inform clinical decision-making and national and global policies. This map, you can see in white treatment sites and in yellow potential sites for the clinical trials. Sorry. We are going to run a short video to give you a bit of background on the endTB project. So today's talks are going to focus on the first component of the endTB project, which is expanding access to new TB drugs, bedaquiline and delamanid. This project is a partnership between national TB programs and, in some countries, private facilities and the endTB consortium partner in that country. The project is implemented in a context of programmatic management. It uses standard monitoring for patients under bedaquiline and delamanid. Patients for off-label use are reviewed by an endTB medical committee, and serious adverse events are reported to a central pharmacovigilance unit. Drugs are procured through GDF and imported through registration or waiver. So WHO recommendations on the use of delamanid and bedaquiline are slightly larger on the use on delamanid that you have on the left side. And you have on the right side of the slide the recommendations for the use of bedaquiline. So the four talks are going to present results on a cohort analysis of patients receiving MDR treatment, including bedaquiline or delamanid. The patients that have received treatment from April 2015 until June 2016. We will focus in 4 countries: Georgia, Armenia, Peru, and Lesotho. The data have been captured in a standard data collection manner in an electronic medical records. And you have in the bottom of the screen just to give you an idea of how the electronic medical record looks like. So we will present characteristics of the patients that have received new drugs, the indications for the new drugs. So we have classified the patients into groups whether they were not four effective drugs were not possible due to resistances or intolerance to the MDR-TB regimen, or whether the patients were at risk of poor outcome. For example, in case of extensive disease, low BMI, HIV co-infection, etc. Sorry, we will also present culture results at baseline at 2 months for the patients that have started bedaquiline or delamanid as part of the treatment regimen from the beginning. We will present serious adverse events. So the serious adverse events are defined as events that have led to death, hospitalization, permanent disability, etc. You have the list in the slide. And and finally, there will be a focus in each presentation on a particular aspect of the implementation in the country that will be presented. Thank you very much. And now it's my pleasure to call Kathy Hewison. She's going to she works for Médecins Sans Frontières. She's a very experienced doctor on drug-resistant tuberculosis, and she's going to present on the findings in Armenia. Thank you.
Thank you, Helena. So unfortunately, the director of the National Tuberculosis Control Center in Armenia couldn't make it today, so I'm presenting on his behalf. So Armenia is a small country in the Caucasus region. It has a capital, or urban capital, Armenia, Yerevan, and the rest of the country is quite a rural context with small towns, and this becomes relevant in the later part of the presentation. The incidence of TB in Armenia is 41 per 100,000, with 11% of new cases and 47% of previously treated cases having MDR-TB. This translates into about 187 new and retreatment cases of MDR-TB per year. Armenia was one of the first countries to introduce the new drugs. Bedaquiline was introduced through compassionate use in March 2013 and went on to programmatic use from April 2015. Compassionate use for delamanid started in November 2015 and moved on to programmatic use in April 2016. So this cohort of patients is 46 patients started on bedaquiline or delamanid, 70% on bedaquiline and 40% on delamanid, reflecting the recent access to delamanid. 4 patients received both drugs simultaneously. 2 of the patients had the new drug added to our ongoing MDR regimen. Most patients were male. 1 adolescent was treated, and amongst the adults, the median age was 47. 13% of patients were HIV positive, and 30% of patients were hepatitis C serological positive. All the patients had an indication for new drugs that was 4 effective drugs was not possible. As you can see, most of this was due to the resistance profile of the patients. However, a small percentage of patients were unable to tolerate normal MDR treatment. 84% of these patients were positive at baseline, and amongst those, 35 were negative at 2 months. Serious adverse events were reported in 8 patients. 8 patients had at least 1 serious adverse event. Of these, 2 patients had a fatal outcome. There were a total number of 13 serious adverse events, and 3 patients had more than 1 serious adverse event. The outcomes are listed below, with 46% of fatal outcome, 23% of not recovered, and 23% recovered. Serious adverse effects affected the gastrointestinal, respiratory, and cardiac systems, the most out of all of the organs affected. One of the challenges in Armenia was how to decentralise care, how to move from a hospital-based centralised model of delivery to an ambulatory-based decentralised model. We didn't want patients staying in hospital just because they were receiving a new drug or other components of the regimen. So delivery site was decided upon several criteria. So the accessibility of the patient to the nearest health structure and what that capacity of that health structure was to deliver the particular treatment the patient was going to receive. The clinical condition of the patient and the treatment regimen, and when possible, the preference of the patient. So we achieved this decentralised model of treatment delivery by using all things available to us. So there was a centralised hospital for referral, the only structure in which patients can be hospitalised. However, 7 regional hospitals can serve as day hospitals, so patients can come without sleeping the night. Ambulatory is available in 60 TB cabinets and 100 health centres, which are integrated into the usually primary healthcare system. We also instigate a home-based care. So this is provided either by the TB cabinet nurse close by, or by a home-based care company, a private company, or by individual nurses that are employed to do this. And lastly, for the second dose of delamanid, which is very challenging because it's 7 days per week, it's twice per day, so the evening dose and the Sunday doses are outside of normal working hours, we introduce video DOT. A particular challenge was the introduction of imipenem. So at the same time as introducing bedaquiline, we also introduced linezolid and imipenem into the country, enabling us to construct good regimens for patients that had XDR and other difficult-to-treat resistance profiles. But this was extremely challenging in a decentralised model. It was possible in a centralised hospital, but we didn't want patients staying in hospital only for this. So it wasn't clear in the country if it had ever been done in an outpatient way, even if it was allowed to be done at home. As I said, MDR patients could only be hospitalised in 1 hospital in the country, and because the imipenem is twice per day, it was also a challenge. The long-term IV access through a portacath also posed challenge because there was no experience with this either. So this was achieved through employing external experts for the portacath, training nurses on use of portacath, and finding different ambulatory solutions to administer imipenem. So regionally, imipenem can be delivered through either one of these inpatient units serving as a day hospital or through the TB cabinets. Then for evening doses, it's quite often home-based care. So 20 cases at this time are receiving outpatient imipenem treatment, and 8 cases are receiving imipenem at home. As I mentioned before, delamanid, the second dose was also a challenge. It was an additional workload for the Sundays and the evening dose. So we started a video dot program. It's using a centralised model with an identified nursing team at the central hospital who contacts the patients every day. The patients were given smartphones to do this with. 17 patients have benefited from this and I'm very happy with it. So we hope maybe to extend this to other patients. So I think it's been a very successful transition from compassionate use to programmatic use in Armenia, and I think having had the experience of compassionate use meant that the scale-up in programmatic use was very easy. I think the innovative solutions to decentralised care have really helped to give access all over the country, even in the rural sector of Armenia. There's still a goal to reduce hospitalisation. Hospitalisation is still takes an important number of days of the treatment in Armenia, so this is a national goal to reduce the days of hospitalisation. And as you saw, 30% of these patients were co-infected with hepatitis C. We've in fact done PCR testing on them. 15% have active hepatitis C. So this is 15% of all the MDR patients. So this is an important number. And we've now got a hepatitis C treatment in the country, and hopefully we'll be able to treat both when necessary. Pharmacovigilance reporting is still very challenging. There's some underreporting, and this is, I think, something that is common across the board, and I think it's something that's just ongoing work to be done with training and supervision and encouragement and experience. Thank you.
Thanks, Kathy. I think right now, if there are any questions for clarification, we'd be happy to take them, and otherwise we prefer to hold questions till the end when we can have a lively discussion. There are questions for clarification? Anything? No? You were crystal clear, Kathy? Thank you. So the next presentation is by Dr. Leo Leca of Socios en Salud in Peru. Dr. Leca will be presenting on behalf of the director of the National TB Program in Peru, who was not able to come, and on the implementation of bedaquiline, and well, in this case, bedaquiline for the treatment of pre-XDR and XDR TB in Lima, Peru. Leo, thank you.
Good afternoon. Thank you for the endTB team for this opportunity to present the progress of this initiative in Peru. Our work is a close collaboration with the Ministry of Health. The Ministry of Health in Peru has the responsibility of the TB patient, and PIH Peru give provide technical assistance. This is the situation, the TB disease and death rates in Peru. As you see, the TB incidence has plateaued at about 90 to 100 per 100,000 inhabitants. Here is our main problems in Peru. The country has the largest burden of MDR and XDR patients in Latin America, 6% of new TB cases and 21 of previously treated TB cases are MDR TB. The last year, Peru recorded more than 1,300 MDR TB cases and 104 XDR TB cases. This represents around more than 70% of the total XDR TB cases in all of Latin America. Another important background point, the treatment success rate in MDR at only 60% and only 25% in XDR. Facing this scenario in late 2012, the Peruvian Ministry of Health decided to begin using a more aggressive treatment regimen, include group 5 drug. The core of this regimen is the 3 drugs, imipenem, linezolid, and moxifloxacin. Preliminary results show that this regimen is improved cure to about 60% to 70% in the XDR TB patient. However, the high cost of this treatment and logistical difficulties, such as the administration of intravenous treatment for long duration using a port cuff, made this a very complicated situation. When the opportunity of the endTB project appeared in 2014, we, PIH, began talking with the National Tuberculosis Program after many coordination, includes numerous regulatory approvals and delays in the arrival of medicine in the country in January of this year. Finally, we received 60 bedaquiline courses plus clofazimine. So we began enrolling the first patient in February of this year. In the following slide, I will summarize the experience with the first 23 patients enrolling from February to May 2016. I want to mention that currently we have enrolled a total of 54 patients in bedaquiline-containing regimen, and several patients are still waiting to start treatment. It's important to know that in Peru, in order to start bedaquiline in a patient requires the approval of the National Committee of Expert Pulmonologists. Two of them are here in the audience. This committee decided to give priority to the use of this drug to patients with XDR-TB patients, and whenever possible to do this by building regimen where all drugs are given by oral administration. This means it takes a few weeks to get approval through this process. These are the characteristics of the first 23 patients receiving regimen containing bedaquiline, clofazimine, and linezolid in Peru. Additionally, they received other medication available according to their DST. 61% are male with an average age is 35 years old. One of the priorities for this initiative has been to expand access to this new oral regimen to prisoners with XDR-TB. This is because many of them were still untreated, as they have not even been able to access the previous regimen. That includes an intravenous TB drug. In the Lurigancho prison in Lima, we have since implemented a treatment room, moving some prisons from different prisons around the country to this room, and now we have several patients in treatment with the bedaquiline regimen. There are 3 on the first cohort of 23 patients is living inside the prison. Another important point is that, as you see, we have no HIV positive patient in this cohort. This is because, as I know, the first patient referred into this program has been very complicated cases with XDR-TB. And we know that several patients co-infected with HIV patients has died before they could start treatment in this new program. This slide shows different indications in patients receiving bedaquiline. Most were XDR-TB, 62%, especially at the beginning, but after a few weeks of experience with the drug, the expert committee began to approve patients with the indication of pre-XDR-TB, either fluoroquinolone resistant and resistant to injectable. In 39% of patients in this first cohort, it was not possible to obtain the DST result, but all have documented treatment failure on a previous MDR-TB regimen. Currently, this ambulatory treatment regimen is provided in coordination with 4 national hospitals in Lima, and also the program is operating in 1 prison. Since about 15% of XDR-TB cases in the country live outside the capital, we are coordinating the transfer to Lima. In 23 patients, 15 have a positive culture at baseline. Among these 15 cases, only 40% remaining positive in the second month of treatment. And I can say that our field team regularly informs us that the patients seem to be improving clinically. As mentioned in the previous presentation, the endTB project includes intensive pharmacovigilance. In our cohort, we observed only 2 serious adverse events in 2 patients, and they were not related to tuberculosis. Here I want to give an example of one of the 2 patients with serious adverse event. It is a patient who was 35 years old, male with XDR-TB, who initiated his treatment as an outpatient in February 11 with a regimen of bedaquiline, clofazimine, linezolid, amikacin, ethambutol, and cycloserine. And later was admitted to hospital in February 27 because of worsening respiratory status. Unfortunately, he died 2 days later. The treating physician and the medical reviewer determined that the cause of death was not related to TB drug. What we see here is that this death is most probably due to the long delay that this patient has to wait before access to this treatment with a new medication. Well, what are the challenges to more prompt and rapid access to treatment with the new TB drugs in our setting? Actually, we have several challenges. A first challenge is to do when the use of delamanid. The Ministry of Health has stated to its approval of delamanid in this program depend on the experience with bedaquiline. In addition, the regulatory framework for the approval process is very complicated, especially because delamanid is not registered in Peru. As far as we understand, the pharmaceutical company has not begun the registration process in the country. Unfortunately, in the meantime, there are already some patients where we have not effective treatment option except to add delamanid to their regimen. There are also challenges for bedaquiline use. Although enrollment is increasing, we have some important items. One is there is only indication for its use in XDR and pre-XDR cases. With 4 hospitals and 1 prison, there are many other patients with fit inclusion criteria, but there are at other treatment sites in Lima and in the provinces. We need to make this drug available at more hospitals and prisons. Another challenge is that bedaquiline is still not in the national TB guidelines. So for every 50 additional patients, we need to go through the regulatory approval again. If the national TB guidelines are updated, however, this will not be necessary. This is true for bedaquiline and delamanid. There is a waiting list of patients mainly as a result of a lengthy process requiring to evaluate and approve each patient to start the treatment. Finally, this slide point is also very important. Without endTB, which include intensive pharmacovigilance, the regular TB pharmacovigilance system is very limited. So there is no other data about the frequency of adverse event and serious adverse event with TB drug. For example, in our experience, we have observed some hearing loss in about 15 to 20% of all NDR TB patients receiving injectable. But when we have asked the national regulatory authorities for official data, this don't exist. And without this data, it has been difficult to make the case for the urgent need for better, safer regimen. In conclusion, we can say that in Peru, outpatient treatment with bedaquiline is entirely possible. A close collaboration of all the partners is critical to expand treatment access, and this last point is something we need to emphasize more strongly in Peru. We need more involvement of community groups of these issues, and not only in Peru. From our experience, we have received queries from many countries of Central and South America seeking support for access to this new TB drug. As I say a few months ago, did a meeting in Panama with colleagues from several countries. We must continue working so that our patient access this new treatment promptly, because it is not acceptable that the new treatment option cannot be accessed and that many resistant TB patients are died as a result. Many thank you to the patient and family who have enrolled in the endTB program in Peru, the Peruvian Ministry of Health and their staff, and our amazing team of Socios en Salud and Partners in Health for this intensive work. Thank you. Muchas gracias.
Muchas gracias, Leo. Are there any burning questions for Leo, points of clarification? Okay. Thank you so much, Leo. So now we will stay in the Southern Hemisphere, but move across the globe, and we'll hear from Dr. Mama about the experience of introducing bedaquiline and delamanid in Lesotho in a setting of very, very high HIV co-infection among MDR-TB patients. And we're grateful to have Dr. Mama, the manager of the National TB Program, here with us today.
Okay. Thank you, Carol. I don't know how to use this. Lesotho, as she has rightly explained, is a kingdom down south, landlocked by South Africa. I think you are aware that Lesotho has been rated one of the very high burden countries. Last year, according to the 2015 report, it was ranked #1 globally. And according to the 2016 report, I think that has since changed. The incidence is now 788 per 100,000 population. We are also having a high prevalence of HIV at 23% as of 2009 DHS. And I have to alert you that that has also since changed, and the prevalence has gone a little bit higher than what you see here. According to our DRS that we are disseminating even at this union conference, our drug resistance in new cases is quite high. It still remains 3.2 versus the 2008-2009 DRS, and also high in the previously treated at 6.8. We are having a low treatment success rate in the overall TB program, hence maybe it communicates well with the high MDR that we see in the country. We started this endTB project, I think it's last year, but enrolling patients we started about October, and I'm going to give you updates and experiences based on the 35 enrolled by the end of May. And 32 of them had received bedaquiline and 3 delamanid, and no patient received both. Of these 4, the new drug was just added to the existing regimen. There were about 23 male, which is 66%, may rightly conclude that TB is affecting male more than women, and the median age ranging from 24 to 62, and high HIV comorbidity. The overall co-infection among our TB patients has never been below 72. I think for 2015 is 72. The indications for these new drugs can see is four effective drugs were not possible. And when you further break it, you'll see that most of them were unable to tolerate the MDR-TB drugs, then followed by the pre-XDR cases, and then the XDR cases. When we started at baseline, the culture, we got 9 positive culture and 9 negative, and 13 no results according to the update then. And at 2 months, we got 4 positive out of the 9 cultures and 1 negative, and yet no results for about 4 results. There was a 7 out of all the 15 severe adverse drug effects who died. And as you unpack it, you'll see that we have those 30 who died, 3 are recovering, 6 have resolved, 2 have not yet resolved, and 2 is yet unknown as to what would be the outcome. Generally, based on the classification, most of these serious adverse effects, 26% of them had to do with the general disorders and administration sites and conditions, and will be followed by the issues on the gastrointestinal, also the renal and urinary at 13%, as well as respiratory, thoracic, and mediastinal systems. The side effect, we are now trying to indicate to you an array of medicines that we are using and to which we have access to in terms of managing our patients. And relatedness to this could not be overruled at 14 patients out of the 23. In addition to these key drugs that are meant to manage the drug-resistant TB, we have that list on the right, which includes the nutritional supplements and other ancillary drugs, and including ARVs. As you can see, that we have very high co-infection rate. So you can imagine if you have to take all this. Here is a case example of a 36-year-old male untreated HIV, and of course CD4 count so low at 19%, and advanced MDR TB. We initiated a regimen of bedaquiline and all those, the prothionamide, the PAS, and 2 days later, this man developed hematemesis, which could be likely to be due to stress ulcers, getting so many drugs. Admitted in the critical condition with pulmonary, pericardial, and possibly central nervous system involvement, and severe sepsis, anemia, kidney and liver injury, and confused with proptosis oculum, a very severe case. The man died of TB disease progression and also stress ulcer, but we could not really find causality related to these TB medications. Challenges. When this subject was introduced to the TB program, we were like, do we think we can make it considering the situations around our lab? But we had a plan B, and the plan B was to outsource the DST also to the neighboring laboratories. That is how we started. Otherwise, the odds, if we hadn't opted for plan B, would have said that we are not getting involved. And then we also experienced that our patients whom are eligible, they are very sick. So the timing of this treatment is quite tricky for us. We don't know, we want to start them immediately because they are sick, but then at the same time we are worried that maybe the drugs are too toxic for them. We need to somehow nutritionally also resuscitate them, stabilize them before initiating them on drugs. So it's something that we also need to understand better and make decisions on in the future. Then accessibility. We are already practicing an ambulatory model of care in Lesotho. All our patients are basically managed from home. They come to facilities every month. But then there are those who are very sick, whom we hospitalize. Those who are sick but not sick enough to be in hospital but still require our observation, we keep them nearer to our hospital so that we can monitor them on a daily basis. So those who are at home, access, because of these side effects which can happen anytime and the toxicity, we need to monitor them closely. So it was a little bit resource intense for them to be visiting as regular as need be, contrary to the standard 1 month visit that we expect because of very difficult, harsh terrain. And I don't know why, but most of our MDR patients are coming from very difficult areas of our country. In conclusion, this endTB project for us it's one way that we saw ourselves as the Kingdom of Lesotho as participating in the global picture, supporting the evidence about the usefulness of these two drugs, and as a result also challenging ourselves to strengthening the current capacity that we have in our lab. We do have a biosafety level 2, but we had some minor challenges which stem even from issues of human resources. So we thought this is going to catalyze what we need to do so that we get our laboratory up and going. Early patients may be mostly sick, as I have mentioned, and outcomes may be discouraging, as you have seen those fatal outcomes that we saw, but we are saying we shouldn't despair because we think that it is a good cause that we are following. Emphasis on pharmacovigilance. Pharmacovigilance is a very important component wherever you are managing these drugs, but then the issue of bedaquiline was sort of a wake-up call for us in the area of pharmacovigilance, for the overall pharmacovigilance in the area of TB medicines as well as ARVs, and the overall, which is currently very, very weak. So it was sent to our department, the pharmacovigilance has to be strengthened to do more than what they are currently doing. So that is how we saw the endTB project at the same time as benefiting the patients and also benefiting the system. And we acknowledge all these people who are participating on this project. Thank you.
Thank you very much. Any clarification on this presentation? Thank you very much. I'm going to invite Mark McNichol to present on Georgia data.
Great, thanks, Helena. So good afternoon. Today I'm going to talk about bedaquiline and delamanid for MDR-TB in a setting of high hepatitis C co-infection. So I have the pleasure of working with MSF in Georgia, which is a country on the Black Sea between the Greater and the Lesser Caucasus Mountains. According to WHO in 2014, the TB incidence in the country is 106 per 100,000 people. There's a high MDR burden in that, and 12% of new TB cases have MDR, and 39% of previously treated cases have MDR, and that translates to around 640 new cases of MDR TB per year. So a little bit of background about the new drugs in Georgia. The first patient received bedaquiline back in 2013 under compassionate use, and bedaquiline has been programmatic use since April 2015 there. MSF were supplying those drugs initially. Now it's through the Global Drug Facility via Janssen. Delamanid began use, again, compassionate use in 2015 and has become programmatic use since April of this year, and that's supplied by MSF. So all of the treatment is facilitated and prescribed by the National Centre for TB and Lung Diseases, and this is supported by MSF, the National Centre for Disease Control and Public Health, and USAID. So just talking about the patients we're actually treating in this period that we're talking about today, 222 patients have initiated either bedaquiline or delamanid. Obviously, with bedaquiline being introduced earlier, the majority of our patients have been on bedaquiline so far, 185, delamanid 37, but as this is now programmatic use, this is increasing month by month. In just over a quarter of our patients, these new drugs were added to an existing TB regimen. So like most of the other cohorts, the majority of our patients are male, over 80%, and the vast majority are adults. We have had 6 under 18s treated with delamanid. Just pointing out one of the high-risk groups for TB, the prisoners. We are now able to give them new drugs and follow them up after some collaboration with the Ministry of Corrections. 11 prisoners received one of bedaquiline or delamanid in this period, and I think that number's over 20 now. And the HIV rate in our TB cohort is just under 7%. So indications for new drugs, as you can see, the vast majority of our patients were unable to have 4 effective drugs without using bedaquiline or delamanid. And around 70% of those are XDR TB or pre-XDR with resistance to a fluoroquinolone. Then we have other patterns of resistance and also some patients who were started due to extensive TB disease or contraindications to other drugs. Again, just looking at culture results, over 2/3 of our patients had a positive culture result at baseline, and out of those, 20% became negative at 2 months. Okay. So serious adverse events in Georgia. We have had 17 different patients out of the 222 who have had a serious adverse event, at least one reported through the PV unit. 9 patients unfortunately died. 28 number is the total number of serious adverse events that have been reported, and the table at the bottom there shows that the outcome, 15 of these being classified as becoming fatal. This slide's just showing the breakdown by organ system of the serious adverse events. The 3 major ones there that are coming out are respiratory as the most common, and then cardiac and hepatic. But with close collaboration with the endTB, we've actually identified more serious adverse events and the problem of underreporting. And this is a problem not unique to Georgia and is happening elsewhere. So we actually did a bit of a retrospective analysis, and we found 15 patients who had treatment interrupted due to hepatic toxicity, which I'll go and talk about a little bit more in a bit. So this is an issue that we have with serious adverse events, again, throughout the whole endTB project in different countries. And this slide is just to illustrate that when someone reports a serious adverse event, we use different terms. So if we look at patient ID 28 there, there were 2 terms used for that, asphyxia and pulmonary hemorrhage. Now, pulmonary hemorrhage would have been the cause of death, and asphyxia the mode of death. But if you imagine every time we report a different SAE, if we use different terms, it's very hard to analyse, especially for the PV unit. Again, if we look at the bottom patient here, 83, we have 3 terms there: hepatic enzyme increased, hyperbilirubinemia, and hepatic failure. Now, all of these are correct, but again, it's just trying to analyse these with the increased volume and number of patients we are having. So as I said, we're talking really about Georgia with a high prevalence of hepatitis C. So it's estimated that the prevalence of hepatitis C in the general population is 7.7%, and from studies looking at serology positive and then PCR positive, it's estimated that 5.4% of the general population have active hepatitis C. Now, just then taking that to a cohort of TB patients in 2013, a study of TB patients looking at hepatitis C showed a hepatitis C prevalence in that group of 21%. And when we look at our cohort of patients, the figure for ours is 20.2%, so that sort of reflects it. And we know that there's increased hepatotoxicity to TB drugs in patients who are co-infected with hepatitis C. And when we look at our group of patients again, 15 out of 56 patients who were hepatitis C positive had their TB treatment interrupted due to hepatotoxicity. So this is a huge challenge going forward for us. So in Georgia, there is a national hepatitis C elimination program. It outrolled its phase 1 in 2015, where they were treating anyone who was co-infected with HIV and hepatitis C, anybody who had metavir F3, F4 liver fibrosis, and people who had extrahepatic manifestations of hepatitis C. Since June of this year, they're now planning to treat anybody who is PCR positive for hepatitis C, regardless of liver disease. The challenge for us is globally, there is not a lot of knowledge and not a lot of evidence about the new hepatitis C treatment, the direct-acting antivirals, in combination with MDR-TB treatment. And obviously, we're using drugs for MDR-TB, which there is the evidence base is building at the moment. So that is a big challenge. And traditionally, people haven't been treated for tuberculosis and hepatitis C together. So we don't know which of our patients have active hepatitis C. They don't routinely get PCR tests done, and that's for a couple of reasons. One, it's relatively expensive, and the second one is that if we're not going to treat them for their hepatitis C, doing the viral load doesn't really make sense at the moment. So just conclusion and perspectives about what we're doing in Georgia. So serious adverse events, we've already started to look into all of our patients' files retrospectively to try and identify all of the serious adverse events so we can record them and also work closely with the PV unit to improve the data for this. In terms of hepatitis C, we would love to have some closer collaboration with the National Hepatitis C Elimination Programme. We would like to have systematic PCR testing for all serology positive hepatitis C patients to work out if they have active infection or not, and then possibly a case-by-case discussion with the hepatitis C programme on whether treatment with the new drugs would be indicated. And currently MSF have a working group looking at developing guidelines for hepatitis C treatment in the context of MDR-TB. So just a couple of people to thank, all of our patients and their families, of course, in Georgia, the National TB Programme, who are well represented here today, and the MSF staff and the government agencies as well. Thanks very much.
Thank you, Mark. Is there any clarification? No. So Carol is going to give some conclusions on these 4 presentations, and then we'll have a final presentation before the questions.
So thanks, Elena, and thanks, everyone. As you can see by the acknowledgements, the work presented here is really reflects the work of an enormous number of people across many countries and continents, many of whom are in the room today. And so there's lots of expertise in the room, both from the endTB project and I think also from other groups who have been working to bring bedaquiline and delamanid to patients who need them. Oops, sorry, advanced. So just, some just overall thoughts as we were putting these 4 talks together. I guess the one thing I just want to make clear is that these 4 projects are just snapshots of what's going on across all of the endTB project, the much larger project in 14 countries. And the idea was to try to provide some hint at the heterogeneity of the settings in which it is actually feasible to introduce these new drugs. Despite really, really high rates, you saw more than 80% HIV co-infection in Lesotho. The hepatitis C issues in Armenia and Georgia, more notably, getting delamanid and bedaquiline to patients in prisons who need it. These are all kind of aspects of the site's experiences that we're facing, and that's because that's where the patients are. One of the things that we're seeing, it's not really surprising, this was true with the initiation of MDR-TB treatment in the late 90s, is that the speed of uptake really seems to be related to the maturity of the program. So in both the MSF sites that we presented today in Armenia and Georgia, there had been at least a year of experience with compassionate use prior to the introduction of bedaquiline through the endTB project. And that has led to larger numbers being enrolled in those sites more quickly, whereas in Peru, as Leo was explaining, there still is a lot of tentativeness around using the new drug. There had been 1 patient treated under compassionate use in Peru before the endTB project started. Decentralization, we're seeing, is possible. There are lots of interesting ways of approaching it. We heard a little bit about that with Armenia. In Peru, that's one of the other things that's going slowly, with just being in 4 hospitals at this point, whereas in Lesotho, basically anybody in the country who has an indication for bedaquiline or delamanid can receive it, despite how difficult the terrain is and the transport. But that's the structure that's been set up, again, because that's where the need is. The safety monitoring, the pharmacovigilance reporting you heard a lot about, and the interpretation, these are all really unfamiliar experiences to TB programs, and quite frankly, it seems to some of the regulatory authorities as well. And so it's resulting in the need for a lot of constant communication with the physicians who are responsible for assembling the reports. We have great support from the Central Pharmacovigilance Unit in Geneva, and then also having ongoing conversations with the regulatory authorities in how to understand those reports. So Leo mentioned that these regulatory authorities are not accustomed to seeing pharmacovigilance on patients with MDR-TB. They don't know necessarily that MDR-TB patients are receiving aminoglycosides that can cause electrolyte imbalances and sometimes sudden death. So it's a matter of, we're all being educated at the same time, including the regulatory authorities in some cases. There was been some discussion about just needing to continue to engage local stakeholders, and that's true for the regulatory authorities as well as for some of the patient groups. And I think the decentralization depends a lot also on integrating more in some of the settings, integrating more clinicians into the management of bedaquiline and delamanid. One of the really exciting things about this project, so we mentioned at the beginning that the target is to enroll 2,600 patients into treatment with bedaquiline or delamanid, and we're up to nearly 700 in just over the first year and a half. And with this 2,600 and also an observational study that will help us to develop evidence that might support broadening of some of the indications for these drugs. As we all know, the indications are fairly narrow. They were based on the evidence that was available at the time the recommendations were made, and there are a lot of open areas for which explicit recommendations haven't been made, but people tend to err on the side of caution in the absence of that information. And so we're hoping to be able to contribute to some of that information or some of that evidence. And then a huge point for the project is, and even really from day one, is thinking about transition plans, transitioning from kind of the endTB project into fully routinized use of these drugs, if you will, and national policies that incorporate a whole range of new interventions. So we've, at the same time that bedaquiline and delamanid are becoming more routine, we've also seen the shortened regimen receive endorsement from WHO, and it's something that programs need to think about is which populations for which populations is each of these interventions appropriate. And now that there is some innovation being introduced, it provides a platform for introducing additional innovation. I made a point in the earlier MSF Symposium about another kind of attribute of making use routine, and that we're continuing to exceptionalize bedaquiline and delamanid, and the current guidance requires consent that's specific to those two drugs. In some countries, that's in addition to a consent to get MDR-TB treatment. In other countries, it's totally unique, and it seems like those things ought to be integrated, and that if consent is required for one drug, it should be required for the whole of this toxic treatment. So these are all things that we're looking at as we move forward in getting the drugs incorporated into national guidelines as well as global guidelines. So you've heard about the acknowledgements within individual countries. We just really want to acknowledge the very important support of our funding partner, Unitate, in this. The donation of bedaquiline from Janssen and managed by USAID, which has been enormously helpful, as well as the donation of some doses of delamanid by Otsuka. We've been working extensively with ThoughtWorks to develop the EMR that we hope will be a platform that countries can use for clinical management going forward. And really, we're just kind of the agents, if you will, of the ministries of health in the countries where we're working. We're just trying to support them in doing what's a really difficult job, and are immensely grateful for the opportunity to be able to work with those individuals and to serve the patients in all of these countries. So thank you. And then this is the endTB team more centrally as well as in some of the sites. So that's the end of the endTB portion. We are privileged actually to have a final speaker in this session, Tiziana Massini, who's going to speak about some work that she did while she was at WHO, looking at opportunities, challenges for registration of bedaquiline and delamanid in the 30 high-burden countries. So a really relevant issue in the context of what endTB is trying to do. And then we'll take questions for the whole session afterwards. So thank you.
Okay, well, good afternoon, and so as it was mentioned before, I'm Tiziana Masini, and today I'm going to present the preliminary results of a project I was working on during my internship at WHO, and the project is about regulatory issues and proposed practical solutions for registration of bedaquiline and delamanid. I have no conflict of interest to declare. So this is the outline of my presentation. I will first give you the project background, so why we got started on this project, what motivated us to get started. I'll give a brief overview about the current registration status for both drugs. And then I'll discuss about the manufacturer's perspective and the country's perspective, in which I will discuss preliminary results. So the project is still ongoing from the country's perspective, and their perspective about registration. So which are the barriers, how do they prioritize in the countries where they want to register. In the last part of my presentation, I will discuss about a very interesting model that is carried out by WHO, which is the collaborative procedure for registration, and how this is currently applied for bedaquiline. And then I will end up with some conclusions and food for thoughts. Okay, so the project, in 2015, NMSF, in collaboration with the StopTB Partnership, published a report which had this title, Country Perceptions for the Implementation of New MDR-TB Medicines. And the report was based on a set of questions, among which there was this question: what are the barriers that prevent countries from the use of new MDR-TB medicine? The main reason that most countries gave was the lack of registration of the medicines and/or companion medicines in the country, followed by concerns about side effects and also economic barriers, so the high price of the medicine. So we all know that in the meantime, countries are accessing bedaquiline and delamanid through interim solutions, compassionate use, expanded access. This was also highlighted in the same report. Import waivers and donation programs as well. However, as the lack of registration was highlighted by most countries as the main barrier to properly implement and use these drugs, and as we are also convinced that registration, so these solutions are very good to have, but they're not sustainable and they cannot be seen as long-term solutions to access these medicines, we decided to start it on the project and to understand the perspective of both countries and manufacturers, because all these partners are involved in the process. Okay, so this is the situation for bedaquiline at the global level. Bedaquiline is currently registered in 42 countries, only 2% are low-income countries, and only 21% are middle-income countries, and 25 files are pending for registration. When we look into specific for the 30 MTR-TB high-burden countries, as defined by WHO for the post-2015 era, bedaquiline is registered only in Peru, Russia, South Africa, and Uzbekistan and India at the moment. So a relatively small percentage of the whole 30 MDR-TB high-burden countries. When we look at the situation for delamanid at the global level, delamanid is registered in 31 countries, 0% are low-income countries, and only 1% are medium-income countries. In 4 countries, the registration is currently in progress, and in 5 countries, the discussion is ongoing toward registration. When we look at the 30 MDR-TB high-burden countries, delamanid is registered in none of the countries. So we decided to get in touch with the manufacturers, understand which are the criteria based on what they prioritize registration, and try to understand their perspective, so major issues they face, and yeah. So we asked first Janssen, so which are the criteria based on what you prioritize the registration of bedaquiline? These are the two main reasons they gave. So the first one is the number of patients treated for MDR-TB per year. They give the top prioritization to countries that treat a higher number of 100 patients per year. And the second major criterion used is the in-country presence of an operating company of Janssen, combined with an interest of the operating company to register the drug in that specific country. When we asked which were the major issues that Janssen faced or is facing, they mentioned that there is usually lack of transparency after dossier submission. Also, when they get the dossier back, it's sometimes not clear what is missing or why the dossier is not fine. And there is lack of efficient communication between the company and the country-level entities, particularly when there is no operating company of Janssen present in the country, while in the case where there is an operating company, the process usually goes much faster and it's more efficient. When we asked the same things to Otsuka, they mentioned among the criteria they use for prioritizing, the first one is the high MDR-TB burden countries that do not traditionally procure through the GDF, and the second one is the countries where the company conducted clinical trials. Among the major issues they mention is the fact that the requirements for registration are often vague, and this fact slows down the process. In some cases, a legal entity of the company must be present in the country to pursue drug registration. There is often requirement of clinical trials prior to a company filing for registration, and also requirement of developing local guidelines prior to a company filing for registration. So we wanted to understand, of course, also the country's perspective, and this is the part of the project which is still ongoing. We aim at targeting the 30 MDR-TB high burden countries with the objective of identifying the main barriers for them for registering bedaquiline and delamanid. So we developed two sets of questions, one for the NTPs and one for the drug regulators. And yes, then we have contacted so far 19 countries, and we got 8, actually, because I got one yesterday. 8 countries reacted so far. So these are the main challenges that were identified. Again, these results are very preliminary. So apparently there is low involvement of NTP in the registration of anti-TB medicines, and it looks like often the communication between NTP and drug regulators could be improved at multiple stages of the process. In many countries there is the absence or weak capacity for drug regulatory functions. I mentioned Somalia here, but this is not the only example. And when we asked which is the role that you expect WHO to play, most countries that we asked so far answered that they expect WHO to play a facilitating role between the drug regulatory authority and the manufacturers. When we asked if countries were, let's say, happy to consider registration, all countries answered in a very positive way, so they're willing to register, but they clearly state that they need technical support from all partners. Alone, they cannot do it. As possible solutions that we want to suggest, a more proactive role and involvement of NTPs could help streamlining the process of drug registration for bedaquiline and delamanid. There is the need of proactively looking for regional agreements for drug registration to overcome situations in which a country has a weak or absent regulatory capacity. And as countries demonstrated so much interest in proceeding with the registration, WHO and the other partners should definitely provide technical solutions in their area of expertise. In the last part of my presentation, I would like to mention about the collaborative registration procedure promoted by WHO. So in this figure, I tried to simplify a little bit how the situation, how the process happens in most of the cases. So the manufacturer has to contact individually each country, and this can mean that they have to submit each dossier maybe in a different language. This is how the WHO's collaborative registration procedure works. So WHO functions as a mediating partner between the manufacturer and a set of countries. So the purpose of this project is to facilitate and accelerate registration, to provide support for countries with severe constraints in drug regulatory authorities, and eventually to accelerate the drug registration procedure as a target timeline. They have a 90-day protocol. The role of WHO in this process is as a mediation partner between the company and the drug regulatory authorities at the national level, and in particular to facilitate face-to-face meetings, information sharing, guide discussions to reach consensus, and moreover providing technical support and question and answer to company and drug regulatory authorities to speed up communication. It's quite interesting. Oh, okay. So if you want to know more about this collaborative registration procedure, you can go to this website, and in particular is the Department of Essential Medicines and Health Products, which takes care of this project. It's interesting to mention that there is a pilot project running involving bedaquiline. And the pilot is actually currently running in 9 African countries, Tanzania, Kenya, Uganda, Rwanda, Burundi, Ghana, Nigeria, and Cameroon, and it got started in February 2016. It's currently ongoing, so unfortunately I cannot say anything about that, but hopefully we will get some results soon. So, concluding, the registration of bedaquiline and delamanid is very slow in MDR-TB high-burden country. Proactive communication among all partners is necessary to streamline the process. And new models, such as the one I just mentioned now, the WHO collaborative registration procedures, are definitely needed. So we are looking forward to the results of the bedaquiline pilot, and they will hopefully get some more insight into this. Countries are willing to register, but they definitely need support from WHO and all partners. And last but not least, let's not forget that indeed the lack of registration is not the only issue to address, and we should all work in parallel to solve other access-related issues. So finally, I would like to thank all these people who helped me and are actually currently still helping me in the project, and in particular Ernesto, Lynn, and Janica from WHO. Thanks a lot.
Thank you, Tiziana. Does anybody have questions for Tiziana? Well, if people do have questions, I encourage you to go up to a mic, and then can we ask all the speakers to come up so that if there are questions, they can be near a mic to answer them, please? So, all the speakers? Yeah. And do you mind introducing yourself, please, Jerry?
Is this on? Yes, I'm Jerry Davis from Liverpool. I just wondered if perhaps we could hear a little bit more detail about some of the hepatotoxicity events, and in particular how they were managed. I'm wondering how often that was treatment limiting, whether the drug had to be discontinued, and also whether any of those events were fatal.
So, in terms of the experience in Georgia with our patients who have been co-infected with hepatitis C, what would usually happen is stop the TB drugs, of course, initially, and then they would be referred on to the hepatitis C program for further evaluation. We actually have had one patient who was treated with sofosbuvir and ribavirin, and is back and then restarted his MDR treatment. He wasn't on bedaquiline or delamanid at that stage, but the general protocol for us would be obviously stop the TB drugs and then try and restart them once the liver function normalizes. And in majority of our cases, we have been able to start them on treatment again. We do have one patient who was not able to start TB treatment because of their liver function, and they are now enrolled in the hepatitis C program, and we're waiting for their viral load and their liver function to normalize before we can start them on TB treatment. So that's really the strategy at the moment, if that answers your question.
Bill. William? Yeah.
Hi, William Wells from USA. Thank you for the presentations. I think I really like the country-by-country style of this because it showed all the different types of variation. Given that, could the project talk a little bit about plans for coming up with project-wide results? Is that something that you plan to present on a project-wide basis, given that there is a lot of variation between countries? And what's the likely timeline for getting a result that's long enough, big enough to give us a feel for the real outcome results and sort of what that would be like compared to without bedaquiline?
Yes. Yeah, so there is part of the endTB project is to conduct an observational study on this first component that we have presented today. So we have started already the observational study as part of the program. So we, as you have seen, the inclusions in the program as such, and of course in the study the same way, are going at different pace in different countries due to several reasons. But probably I can guess that after 2 years of running the project, so maybe by the end of next year, we can have some preliminary results on the overall program from several countries, and we expect that in 4 years we can have final results.
And so what would the comparator for that analysis be?
Sorry, excuse me?
The comparator for that analysis?
The comparators. So we are going to look at mainly the two main outcomes are going to be patients' outcomes, program outcomes, and adverse events. So on these two aspects, we'll have several indicators. The idea is not to compare countries. The idea is to have patients from different contexts coming in a pool of patients and having results on the overall project. And then, of course, if we find that there are things that we need to compare between countries, we'll do as part of the study.
But there's no plus and minus bedaquiline?
There's no comparison group. It's a cohort of patients receiving either bedaquiline or delamanid.
Okay, thank you very much for the excellent presentation, Ciaret from UCID. I just wanted to know a bit more about if there's any data comparing mortality, because those countries have been implementing the basic MDR treatment for some time. So is there any difference already in mortality between standard treatment and after the introduction of new drugs? And at the same time, maybe also another comparison in terms of duration of treatment. Has there been a change in either extension or shortening of the treatment compared to the standard regimen?
Yeah, thanks for that question. The second question first, we're adding these drugs to a standard regimen. So we're not changing the duration of the treatment. So it's 20 months or 24 months based on cultural conversion and that type of MDR. So because it's still a 2-year treatment, one of the first countries to start was Armenia under compassionate use with bedaquiline, and the last of that cohort of patients are coming to finish their treatment soon. So only then can we compare a whole cohort of patients to another cohort of patients. And we do have cohort data from Armenia and Georgia and other countries retrospectively, so we will be able to compare, but only when these patients have finished their treatment. Because we talk a lot about what happens at 6 months of treatment. That's not the end of the treatment, it's 2 years. It's only when we do the clinical trial, which we haven't presented here today, that it will test shortened regimens and combinations of the new drugs.
Okay. Does anybody else want to add anything to that?
Actually, there's no need to add because we really don't have numbers to compare. Like she has rightly mentioned, we are here to observe what will be the cohort outcome, and then we can be able to tell you the difference. Right now, we are just sharing a direct experience in terms of what has transpired without necessarily comparing anything.
Please go ahead. Oh, sorry. Oh, yeah. Leo, sorry.
No. I would like to add that in Peru and in other countries, but now we are working with the worst patient, I would like to say that probably this scheme is a unique opportunity for this patient, and now we're working for that.
Yeah, I think this is another, I mentioned before the similarity to when programs first started treating MDR-TB patients and kind of the pace of enrollment. One of the other similarities is that a lot of the projects are seeing the sickest patients get access to bedaquiline or delamanid first, and the hope is that in time it will be a more heterogeneous population, some with fewer risk factors, but we shall see.
Thanks a lot for this very nice session. I had a question to those of you who are working in a setting with high HIV and MDR-TB co-infection. I was wondering how many of these patients are actually also receiving antiretroviral treatment? And secondly, what would be the most important drugs for you guys to have available to actually use in combination with bedaquiline and delamanid?
The target for all our TB patients is to initiate them on ART, and we are now embarking on the test and treat. So all of our MDR patients are on ART. It's a very aggressive approach, but that's what we are trying to do. You remember one of my slides, I was indicating the key drugs that are used, and then the several ancillary drugs to address the side effects as well as the nutritional component. And there's a whole lot of them, including the pyridoxine and antiemetics, antidiarrheal. All of them, we give them even without fail, because we have realized that most of our patients don't really escape all those side effects. So that slide, it was an indication of the numerous drugs that we administer in addition to the regimen of antibiotics that we are giving.
I was thinking in terms of antiretrovirals, which ones are the most commonly used for
Okay.
you guys?
The standard regimen is that we use TDF, 3TC, and sometimes nevirapine, and sometimes we replace nevirapine with efavirenz. Yes.
Thanks.
I'm Peter Sigelski from the US CDC. I'm sorry if you said this, the session is so popular that they actually weren't letting people in for a period of time. Oh, no. So if you covered this, I apologize, but is anybody doing susceptibility testing for bedaquiline and delamanid, and have any of the programs observed acquired resistance to those two drugs?
Yes, thanks for the question. So we do send samples on patients who are still culture positive at 6 months. We send them to Antwerp or to other, well, in fact, for all of these projects, they all go to Antwerp, where they can do bedaquiline DST. As of today, I don't know of any resistance, except from another project, which is not part of endTB, and the patient had bedaquiline resistance, and the patient had never had bedaquiline. So it was quite a strange case.
And so there was no, among the patients who received bedaquiline, no acquired resistance that anyone has observed so far?
So far, not from my knowledge, yeah.
Thank you.
But maybe Antwerp as well.
Come on, apparently you're a privileged group to be inside the room. No more questions. Yeah?
Hello, I'm Dr. Pema from Bhutan. My question would be to the panel, because I think after 40 or 50 years, we are getting a new drug. So what would be the advice, like, because we know that MDR has been caused, and we often say it is a man-made phenomenon. So what would be advised now that we have two new drugs? I mean, it will be so popular. If it comes in the market, I think most of us would be using it, even for normal TB. I mean, we do not rule that out. So what would be the advice to just follow up on the question earlier to prevent the resistance or the availability of these drugs in the market? Thank you.
Maybe Dr. Mama? Oh,
yeah. I'd just like to give my opinion, because I think one of the major challenges is to regulate the drugs in the countries. And in countries where they regulate the access to TB drugs through national TB programs, it's much less of a problem. But we see some countries where there's no regulation and we see these patients coming through the endTB committee. The patients have received 2 months of this, 2 months of that, 2 months of this, and it's because there's no regulation in the country about who can prescribe the drugs. And this, I think, is the key. And I think it's not about registration of the drug in the country. It's about regulating who can prescribe the drugs and therefore have access to them. And I think if the right people prescribe the drugs, I have confidence that they're going to use them correctly.
In addition to regulation, and as far as we are concerned, we realize that our pharmaceuticals in Lesotho, they are not really interested in selling these anti-TB drugs. They come costly, and because we have an arrangement with the private sector to provide them with these drugs, they tend not to be interested in procuring them. I don't know whether it is a safe thing to think that it will be safe as far as that. But yes, strengthening our regulatory authorities is something that is also going to protect the community.
I just want to add one thing on behalf of our colleagues from IRD who are, I think, really pioneering an approach to making these new drugs accessible in settings where there is a lot of private practitioner involvement in the treatment of MDR-TB or TB in general. And I think we've learned the hard way that we can't just say no, private practitioners can't get access to TB drugs because patients go to see them. And so IRD is working to try to develop mechanisms in several countries that will allow private practitioners to be able to treat patients who need these drugs, but with careful oversight and connection to the national TB programs. And Usma Khan is here, and I'm sure would be happy to talk more about this approach if people are interested.
Sorry, Anthony Byrne from Australia, respiratory physician. Thanks for the presentation. I just had a question. I'm sorry if I missed the very start, but just in regard to monitoring of side effects, I imagine that it's sort of program dependent and country dependent in terms of symptoms, blood tests, liver function tests, ECGs, etc. Maybe people could comment about what's routinely done to sort of pick up some of these side effects before they become sort of particularly obvious.
Do you want to take that, or Kathy?
Yeah, maybe I can just answer, and then you can give some more details. So overall, there is a central pharmacovigilance unit where the serious adverse events are reported to, and that's within the frame of the endTB project. And of course, this is depends, as you said, depends on the country and on the mechanism that the country has set up for that particular country. But as a project, there is a central PV unit. Maybe on the monitoring, there's also a slight difference. Maybe you can comment on the slight difference.
The monitoring follows a fairly standard approach. It's similar to WHO, some baseline cultures, visual testing, color testing, neurological test, blood test, liver function, full blood count. And then these tests are done monthly, basically every month. And in some countries, there's some slight variation on that. And of course, ECG, sorry, I didn't mention. But in general, it's the same basic programmatic monitoring that is recommended by WHO and by endTB clinical guidance, with maybe minor modifications in each country, but generally the same.
Sundari.
Hi, Sundari Mesa from WHO Country Office in India. I just wanted to share the experience so far. I don't know if Dr. Malik Parmar is in the room, but he's been at the head of implementing bedaquiline in India, and it's been rapidly scaled up now with a nice pharmacovigilance program that's been put in place. And I think there's approximately some 70 or so patients at this point started, and it's been a good experience so far. Getting to the issue of private sector, bedaquiline in India right now is only available through the public sector program. And I think that's going to be kind of a key to ensure that we don't have use of that drug with potential acquired resistance. But I'm sure that we'll be able to share more data next year at this time. But the plan is to have 600 patients started on bedaquiline through donation from the company and then within the next year.
Great, thank you.
Hi, Michael Rich from Partners in Health and co-leader of the endTB project. I just wanted to mention that on the endTB.org website, there is a free clinical guide on how the programs use the drugs, how they build a regimen with new TB drugs, how the list of indications and who we use new TB drugs in are there, and how we manage side effects and a monitoring schedule of what we suggest to how frequently to do ECGs and blood counts and things like that. So please go to the website and download the free clinical guide for more information.
All right, so I think our time is up, but thank you so much for your attention and participation in the session. Thanks to all the speakers for sharing the experiences in the countries, and we look forward to reporting back next year with even more numbers and longer-term outcomes. Thank you.
Thank you.